patient to the PMR IPT. The problem what we face whenever the referral has been made from the other departments like neurosurgery, the general medicine, the ICU, Dr. Sir, please take the patient back to rehabilitation ward. Patient need IPT rehabilitation. So first thing that comes in my mind is whether to shift the patient or not. So when to shift the patient? This is the first question, and when the patient is being shifted, first should be the goal about the shifting and the rehabilitation. That's why I have created this topic, the goal setting in the spinal cord injury. Because goal is very important in each every life. I tell you, come to Patna, and you came to Patna, but you don't know why you have come to Patna, what I will do there, and what I am supposed to achieve. This is a big sort of thing, na? Shift the patient to the PMR IPT for rehabilitation. So you need to be very specific in that regard. Now you came to Patna, you know you are here to attend the masterclass. Okay. So you are coming here, getting yourself registered. Now everything is clear in your mind. And step by step you are achieving it. First registration, then you are planning for travel, then coming here, boarding in the hotel. Now coming again to the registration in the early morning, to the e-class. Now you are attending this. Now you have a sense of fulfillment and achievement that for the purpose, the goal which I have set, now I am achieving it. So it is very important to have a goal in life for any patient or person. So as we all know, acute SCI traumatic event that result in disturbances to normal sensory, motor and autonomic function. Ultimately it impact physical, psychological and social well-being. So rehabilitation, we all know, process of enabling and facilitating the restoration of a less able person to regain optimal functioning physically, socially and psychologically to the level he or she is able to or motivated to achieve. The definition is given by Walter in 1996. It is defined as a formal process whereby a rehabilitation team together with the patient or their family negotiate and set goals. It is a very formal process. Don't make it an informal sort of thing. Be formal and discuss it, as I said, written here, patient and their family. If patient is able to take his decision on his own behalf, or if patient's family is involved, then you must negotiate this. It's not like whatever you say will get it achieved. We will negotiate the realistic way, the practical way. So it has 4 procedural elements. The goal setting has 4 procedural elements: assessment, evaluation, assignment, and intervention. Obviously, you have assessed the patient. That's why you have let the patient allowed to be in your ward. Now you will do again evaluation, the physiatric evaluation, so that what are the things the patient have and what are the things we need to be achieved, and then you assign the task. Task assignment is very important. It's not only physiatrists who are involved in the rehabilitation or goal setting. We have to discuss it together, as I have said, patient and the patient family. But again, with the nursing officers. At our place, we call the nursing officers, the therapist, occupational therapist, the physiotherapist, the prosthetic and orthotist, everyone. Also take the opinion from your residents. Okay, regarding they will be make themselves feel part of the rehabilitation goal which we have set. Then we will finally assign the task to them. Tomorrow when you will visit our ward, you will see there is a bedside, there is display board is there. There is everything is written there: patient profile, patient short history, what investigation, what diagnosis and what intervention treatment is going on. Along with that, you will see there are goals. Defined goals for therapist, physiotherapist, occupational therapist, prosthetic and orthotics. In case of prosthetic and orthotics, we have set a deadline when we are going to deliver these devices to the patient. So we have made it like here. Even nursing officer goals are set there. So that in the ward round, we can discuss them with them. What you have achieved and what is left and where you are facing the problem. So each rehabilitation cycles, goals are repeatedly set that determine assignment and appropriate intervention. It is an essential component of structured rehabilitation. It's not an optional thing. It's an essential component. Okay, so goal setting begins during acute care when the primary goal is to stabilize the patient health. It's motivating the team and patient as well. A small steps, a small achievement is a motivational aspect of the patient life as well as our team. as I said, motivational aspect. Because the patient just know, yes, I have lost everything. I have traumatic paraplegia, all another problem, pressure ulcer problem, unable to walk, never able to walk in my life. Okay, I have lost almost everything. But he has still the hope of life, not life. Life has been saved, but life needs to be returned back to the patient who is surviving with all the hope and dreams. So it will motivate him. Okay, we will first let you just take this holding this, standing, sitting, balance, everything. It provides a means for the team members to evaluate the rehabilitation process. We will also evaluate whether we are going in the right direction or wrong direction. We are really achieving anything, but just let it be, just giving the round and going again back. And also evaluate the planning and means and method which we are using. Okay, you are trying to do something to manage the spasticity. Whether it is working or not, how can you be stressful? The pressure injury you are managing. But every day evaluation, you need to take pictures and whatever assessment scale you are using. Whether the pressure injury you have seen yesterday or 1 week before, improving or not. What is happening to the bladder and bowel? Why is the patient not able to still sit or hold his knee, okay, sit by the side of the bed, whether he is ready to do this toilet, this is tiltable or not. So it's a thing we need to evaluate every day. And Philip would put it, if healthcare processes are to be evaluated, they must be goal-oriented, because the appraiser is the only concerned with the extent to which goals are attained. It's not like it is quality audit also. Goals need to be set, goals need to be achieved. But the goal must be relevant, unambiguous about what should be accomplished. There should not be any confusion regarding the one goal as set, it should be unambiguous. Positively defined, put in behavioral terms, easily and clearly understood by all team members, attainable, allowed planning, and measurable. Goals should be set in terms of activity of value to the patient. Ultimately, whatever we are doing for the patient. And if you are not providing anything in the terms of activities of value to the patient's life, how it matters? What goal you have set and what goal you are trying to achieve. So, rehabilitation goal, these are the small thing only. You can use this SMART or Rumba criteria, okay? Just to memorize or answer the question during your examination. This is SMART criteria or Rumba criteria. It's specific, measurable, attainable, realistic, and time bound. And relevant, unambiguous, measurable, behavioral term, AI forgotten. Key is to need to be addressed. Do the patient and team members always understand the goal planning process? Are the goals always the patient's goal? And are the goals forgotten once the goal planning meeting is over? So we need to reevaluate, periodically, assess, retrospect, introspect among ourselves where we are going with the goal. Documentation. These things I must emphasize. Like I am collecting the data from my department since 2015 or 2014. In August, we admitted first patient in PMR IPD. And the file we have seen, our own file, we are feel very bad about it. How badly we have managed our own file and data. There is nothing there. Just patient admitted, no skills used, nothing specific advice is given. Even discharge summary is very less. So 2015, I am evaluating my own file. Here, how I have fared in data collection in my own department. But slowly we have improved a lot. So documentation is very important. Don't underestimate this. That's why in research field, as a physiatrist, we are lagging behind so many specialties. So documentation, whether it is achieved, not achieved, ongoing, goal need to be revised, or goal abandoned. Sometimes it happens. It's not like each and every time you will succeed or you will get success. To accept it with respect and honorably. That this is the goal which need to be abandoned. Doesn't mean that you abandon the patient. You are abandoning the goal which you have set. That means again you are facing the same challenge. The day you admitted the patient. Why you have admitted the patient? You have admitted the patient for rehabilitation. There is rehab challenge there, rehab goal there, and there is methodology by which you will get the goal accomplished. So again you will set the new goal. So obviously. Secondary complication, neuro recovery, maximizing function, improving patient ADL, helping the patient accept new lifestyle. This is very important. Helping the patient accept a new lifestyle. Now his life has changed, totally changed. Yesterday he was enjoying a bullet ride, hearing this earpad and iPad, iPhone, whatever it is, and in a minute his life has changed. Now he had to accept it. And you are the key person who are able to make this happen to the patient life. That this is your new lifestyle. Okay, life has been saved. Now this is your new lifestyle, and we will help you in adjusting with the new lifestyle. Okay, and ultimately facilitate community reintegration. Focus on primary motor control, activity-dependent neuroplasticity, and restoring function by remediating underlying impairment, step by step. As the concept is time is time. In fact, every medical aspect there is time is everything. So emphasize the importance of early transfer to a specialized center. When to take the patient? Usually we take the patient. We never usually prefer to take the patient from the ICU. We tell our colleagues first you transfer the patient to the normal ward. From the normal ward we will assess the patient, and if the patient is vitally stable, no requirement of oxygen. Okay, then we will take the patient. But it doesn't mean that the patient is tracheostomized, patient is on rice tube, patient is on catheterization, IV fluid antibiotic is going on, and patient is active monitoring. We will not sick. We will sick. We will sick. Definitely sick. Without any fear, we will sick the patient. You are doctors. We are specialists. Okay, patient, if you emergency care, that is totally different thing. Even in that setup, you don't refuse referral. You tell them, write in the referral sheet. This is the condition of the patient, this is your opinion, this is your assessment finding, and patient needs rehabilitation. You will provide rehabilitation that will be provided bedside. But don't refuse. Referral is a respect. So you respect it also. Don't lose this opportunity. You give them, we will provide the rehabilitation support bedside. And we will shift it or review it after a day or 5. But always go there, face the patient, learn something from the patient. Learn from your prescription whatever they have prescribed. But never refuse your referral. Whenever you are transferring, be judicious. Don't be heroic. Always, my advice is, shift the patient from the normal ward. Tell them, you shift the patient first to your normal ward. Then we will shift them from there to our ward. Early rehabilitation to affect long-term outcome. It is very important, you start early. Management has been the recognition and prevention of the chronic complication of SCI. Okay, directed intervention along with early reintegration of physical rehabilitation and mobilization. That can be done in acute setup also. So go there, advise, pediatrician advice, and let them see the result of the rehabilitation. So there are many things like the key questions should early rehabilitation can be recommended for individual SCI. There is not a lot of literature. You will be very surprised to see there are not a lot of literature or not a lot of articles regarding when to shift the patient from the acute setup to rehabilitation ward. There is no such guideline, protocolized guidelines. I searched a lot, but I didn't find any specific. You can also search and help me in this regard, so that we could have a strict guideline when to shift, because you feel a lot of time very precise. No, shift to the patient. We need to wait to be given to someone else. So recommendation is, we suggest rehabilitation to be offered to patients with acute SCI when they are medically stable, I just said, and can tolerate the required rehabilitation intensity. That you can answer to the consultant, because rehabilitation is a very intensive thing. And if patient is unable to participate actively in the rehabilitation or unable to tolerate the rehabilitation, then boss, there is no point in transferring the patient. You are just taking your patient to our ward. But we are not able to do anything now. Just let the patient be there. You manage that. You will take it definitely. Let it come to that phase. But always talk to the consultant. Clear their doubt. Not like they will think, no, PMR especially they are not taking my patient. They will just discharge the patient. They will tell the family member, no, we will take the patient outside and go somewhere. We are not taking your patient. Sometimes they do it. But the strength of recommendation is big. In adult patient with acute subacute traumatic SCI, there is a time interval between injury and commencing rehabilitation affect the outcome. What is the comparative effectiveness of different rehabilitation strategies, including different intensities and duration of treatment? Are there present or injury characteristic that impact the efficacy of rehabilitation? What is the cost effectiveness of various rehabilitation strategies? This is core PMR thing. All 4 points are core pediatrics thing. So much ponder about it. Okay, how it's going to affect the patient. Okay, very important. What strategy we are adopting, how literature has been supported that strategy, what are the various literatures are saying about it. Then you formulate after talking to the faculty and consultant, so this strategy can be employed in our case. And slowly you will develop your own database. Okay, C4 level injury, traumatic injury, conservatively managed, patient reported after 72 hours, reported at emergency, there is nothing serious in MRI, CT scan, you see the patient with this abnormality, and you take care in phase 1, phase 2, phase 3 by manner, short-term goal, long-term goal, and this actually work. If it works in 10%, then definitely it will work in 12%, okay, 15%. If I might be failing to 3%. So slowly you will develop your own protocol based on the new literature and other what experts are saying. So desirable effect of this neurological outcome will be better, activity of daily living, ambulation, quality of life, reduced rate of mortality, and reduced rate of rehospitalization. If we start rehabilitation early, it is also important. The reduced rate of rehospitalization and secondary complications. So early rehabilitation is very important. Everyone is telling yes, early rehabilitation, now the time for rehabilitation. But do it in your own setup, your own ward, or someone else, it's up to you. But early rehabilitation, there is no doubt about it. Comparing outcome between an early and late rehabilitation, there are no studies that directly compare outcome. That were, however, retrospective cohort studies that reported that an increased time between injury and rehabilitation is associated with reduced function and quality of life. There were also mixed reports on whether the timing of rehabilitation is associated with the risk of rehospitalization ulcer. When confronted with a life-threatening event such as SCI, patient and individuals are understandably eager to initiate rehabilitation and begin working towards recovery as soon as possible. They have injured, they have so many doubts and confusion in their mind. What will happen to me? What I will do? Because other specialists are mainly concerned about saving the life. They are not even talking to the family members. They are not even talking to the patient. If the patient is conscious and cooperating, able to understand. You will be very surprised during the round, the resident, the consultant, faculty, everybody is discussing among themselves. But very few is really talking to the patient. Apart from seeing the patient, making an eye-to-eye contact during ward round, you are standing by the side of bed for almost 10 to 15 minutes, 20 minutes, sometimes, and you are discussing everything that is totally not understand by the patient. He understands that something is discussed being discussed about me, but he is not able to understand. So it is very important. His life has been gone in his own definition. So you tell him. So rehabilitation is very important. It will give him hope. Okay, life has been saved, now we will give him back the life. There are certain undesirable effects also. The only possible is increased transfer back to the acute care. You cannot, suppose you have taken the patient back enthusiastically. Okay, I will rehabilitate, no problem. Send the patient to my ward. But actually, patient is not able to participate in rehabilitation, tolerate the rehabilitation, and develop certain complications that you have not seen or foreseen. Then what will happen? You will again request the same consultant and faculty. Boss, please take it back. Patient, something wrong with the patient. He developed some certain complications we are unable to manage. So this thing you have to foresee. Don't be afraid of that, but you have to foresee this. Again, you tell the consultant same thing before sitting the patient. If something bad happened, patient regressed and deteriorated, you must have this patient sitted back to you. The GDG, this guidance group, unanimously agreed that the anticipated undesirable effects are probably small, and that the desirable effects are probably large related to the undesirable effect. It means this early rehabilitation they are supporting. This you can get in anywhere during it, spinal cord injury, the level wise disabilities, the level wise functional goals, and what are the equipment patient can use based on level of injury, and how these equipment will help the patient in getting these functional goals. These all things we will give it to you. No need to take photograph. We will give everything to you. No worry at all. Okay, everything, printed, video, everything. Okay, we'll give it. So these are certain things like if you have anybody C1 to C3, the ability patient had, usually head and neck control, okay, and these are the daily tasks. These things you will get, you are not reading it out. So, no, I have not said thank you. Okay, it's written here, I have not said. Okay, so you understand my point. Okay, residents, because this goal setting, we have very less talk about it in our conferences. So actually I think that it's very important. So hopefully I am able to convey my message to you, this goal setting and this timing rehabilitation. Now I will say thank you.
Thank you very much, sir, for excellent presentation.
सर
आ गया सर बोल रहे हैं लाइट आ रहा है
सर
साइड पे करना पड़ेगा यार साइड
सॉल्व